السلام عليكم. أهلا بكم أهل العراق. إن شاء الله تبقوا بخير وفي أمان في الأوضاع اللي احنا فيها، الكورونا فيروس بانديميك. أنا اسمي الدكتور أشرف رفاعي، ويعني يحصل لي شرف النهاردة إن أنا هدي كده فقرة بسيطة على العراقي دنتال كلينكس. طبعا دعوة من الدكتور مصطفى يوسف والقاسم العبادي، وطبعا منظمة من الدكتور أحمد نحراوي عندنا هنا في القاهرة. طبعا أحب أكون معكم في العراق، بس الظروف الحالية لا تسمح بذلك، بس إن شاء الله ربنا يعني يفرجها على الجميع، وإن شاء الله أجيلكم هناك في العراق. A little about myself. I'm an associate professor of endodontics. I've been practicing endodontics for about 25 years. أنا بشتغل في كلية طب أسنان جامعة الأزهر، قسم علاج جذور. I'm a former head of department, الحمدالله. And the screen in front of you right now has all my contact information, my emails, my blog, and you can scan the QR codes to join my personal page or my formal page. Okay, the topic for today is how to deal with instrument separation. And we need to define the difference between instrument separation and fracture. Fracture, فعل فاعل. Separation, it just happened. مبني للمجهول. So when you come to inform your patient about a fracture, you should always say the instrument separated, مش it was fractured. And my experience as an endodontist, I generally get a lot of referrals of instrument fracture. And this is ده الإحساس اللي بيبقى عندي when I get the instrument fracture. Okay, you can see this is very clearly. There's two instruments fractured. This is an X-ray from my friend and my brother, Dr. and you can see the instruments. You have an anterior spiral fractured in one canal, and you have the tip of an instrument fractured in the coronal portion of another canal. And things like this come to me all the time. I'm always hoarded by these type of cases. And then what happens when this nightmare occurs? What do you do? How do you manage? These are all, by the way, these are all my cases. These are not cases from other people. I fracture instruments as well. I'm not saying that everybody else fractures instruments and I don't. And there's no living endodontist that doesn't fracture instruments himself. So, what do you do when this happens? Most people, they start doing this, then this, and then after a few years, you get a failure, or it comes back from the dead. You get an abscess or a swelling or pain related to your tooth. Now I'm going to start by showing one case. This is a 32-year-old patient. She had a lower premolar. You can see it right here, and the lower premolar had complex anatomy. It had very long roots and very severely curved root here. It had 3 root canals and a very deep bifurcation. You can see it very, very clearly. Very complex anatomy. It was referred from a dentist, his daughter. So I was I was trying to be very careful when I was dealing with this case. And obviously you can see here, what do you see here? This is another instrument fracture, not mine. But the dentist previously he did an instrument fracture on that canal, but he filled over it. Okay, so this is a CBCT view. You can see that there are 3 canals very clearly, and very clear exit of the canal. There you have a very big lesion. So you've got a very clear view on the axial view of its anatomy. While you look at the sagittal view, you can see the depth of the bifurcation right here, and you can see the lesion opening to the distal of the root. And yep, very clearly there. While if we look at the coronal view, you can see that the root is very much very close to the mental foramen. There you can see one of the roots is actually inside, very in proximity to the mental foramen. Yeah. So I had to be very careful because I didn't want to overextend anything. Plus, surgery was out of the question. Alright, so I did the normal, I did length determination, I determined where my apical foramen were, I started doing my glide path, and all of a sudden, fracture. That was this SC2 instrument from the old Revo system. And usually when this happens, everybody begins to panic. So the best solution in this situation is to do the canals you can do, and then start dealing with the instrument fracture later. So that's what I did. I obturated the other two canals, and I started doing my final canal. Here I had a bypass attempt. I was lucky, I bypassed, and this is the situation immediately post-operative. You can see here that this, you think this is actually a root. The exit of the canals are to the distal, and you'll see that in the post-operative x-ray with the healing, because all of the lesion is on the distal surface of the root and not at the tip. And you can see this is immediately post-operative. You can see the lesion here and here. After 2 years, the apical area is no longer inflated. There's a continuous lamina dura, but you can see there's a slight widening of the periodontal membrane space at the exits of the canals, but definitely an improvement from the pre and the post-operative. Very clearly you can see here a very large lesion, and here nearly normal. This restorative work was done away from my clinic. I don't know what happened here. I think somebody perforated while creating a post space, but this patient came to me 2 years later. Okay, so what are the possibilities if this happens? You have trilate removal, محاولة انك تشيل الفايل من مكانه, bypass, تعدي من جنبيه, apical surgery, جراحة, تشيل ذروة الجذر, and to obturate over it, أو تردم عليها وتحشي عليها. So the question is here, why not to obturate over it? And this is very important because a lot of dentists believe that this is an option. A lot of them have been taught this at their primary dental education, during their primary dental education, and this has to be changed a little bit because we have to understand that the problem is bacteriological in nature. We measure bacteria in the microns, 1 micron, 2 microns, and if we look at the canal diameters and sizes and spaces, for instance, a size number 8 file is equal to 800 microns, while a size number 40 file is equal to 4,000 microns. So you can imagine the amount of bacteria that can be in this 800 microns, not to mention that the canal tapers, there's irregularities in the canals, there's dentinal tubules, there are isthmuses, fins, irregular spaces which cannot be touched with our instruments. And this has been proven time and time again, just like the O.V. Peters study. So argument number 1 that we were taught at university was instruments separate at the apex, so they are as if they were obturation. The argument number 2 is the instruments separate after canal preparation, so I'm sure that I've cleaned the canal, so it doesn't make a difference. These are the 2 arguments. So for instance, this is an instrument which I fractured, and you can see this instrument is fractured within the canal, and what do you see over here? Space. These instruments are not solid and they're not compactable. So these flutes have the possibility of harboring bacteria, this flute space. As again, you can see from this slide that the instruments themselves are irregular in shape and they contain spaces around them. The canals themselves are not rounded. The canals themselves can contain irregularities. You can see over here there is irregularity, even though the canal, the round area represents a file, but there is still space around these cross sections. And we've seen from studies like the Verna study and that this is a micro CT study of the maxillary first molar teeth, the mesiobuccal root, and you can see that the extent of complexity of these canal systems, even if you could get into one of these canals, two of these canals, physically it's nearly impossible to manually negotiate a canal system. So we rely heavily on irrigation and hydraulic pressure during obturation to fill these irregular shapes. Even again, these are studies from 2018, 2016, relatively old studies. But no matter what the studies, these were all antibacterial studies done on canals, and to see how effective cleaning techniques, activation techniques, and preparation techniques can reduce the amount of bacteria within the canal systems. And none of these papers reported a complete sterilization of the systems. Yes, a reduction, but complete sterilization is nearly impossible. So there is always going to be an amount of remnant bacteria within the canal systems, which we try to keep under control by obturation and prevention of this bacteria pushing itself into the apical area again. So which one should you choose? Obviously, obturating over it isn't an option, so you're left with trilate removal, bypass, and apical surgery. The bypassing is definitely the treatment of choice. Whenever I have a chance, كل ما يبقى عندي اختيار ما بين إن أنا أشيل الفايل أو أعمل bypass، أنا بختار الbypass. I know that the emotional decision, الرد العاطفي, is that you want to get that out of the X-ray. You don't want to see that anymore. You want that file outside, and you don't want it in because you feel that it will affect your image of your post-operative. It's some sort of ihana or insult to you to leave it in the canal, even if you bypass it. So as a start, I would suggest doing a bypass, and that is what is in your patient's best interest. So why? First of all, bypass is less traumatic. Any removal system, any removal technique involves removal of dentin and damaging of the root canal system. It's less expensive. You don't have to buy specialty equipment. You use minimal technology. Basically, you use files. And sometimes, if you're lucky, the instrument pops out without any effort and with the need for expensive equipment. So how is it done? I know there are a lot of people who say we have a protocol, and there are protocols, and basically it's very simple. You use small files, minimal force, and a lot of patience. This is what it takes, because there's a misunderstanding that when you're bypassing, you are actually forcing a new canal to be created. The steps of bypass is very simple. You try to find space between the instrument and the canal walls, and once you've found some space, you begin to inch forward, hopefully finding your way within the flutes or within any space between the instrument and the dentin until you bypass the instrument. Once you've done that, you enlarge the canal to larger sizes and create a bypassed canal or a bypass canal next to the instrument. This is what it takes. It takes a lot of patience and effort. Sometimes it works, sometimes it doesn't. So here you can see this is an instrument I fractured. I fractured it beyond the curve, so it wasn't visible in my microscope. I started doing the sequence of bypass. I came from the internal surface. I always come from the inside of the curve because the instrument has a tendency to open up. If it opens up against a metal object, no problem. But if it opens up against dentin, you can start ledging and perforating. And this is the final where I bypassed and obturated to the apex. So the order of things here would be bypass first, if you have the option for bypass. Then if bypass doesn't work, then you try at removal if it's possible. And then finally, when all things fail, apical surgery is what we need to do. So the question is here, when do we choose instrument removal? Obviously, when bypass doesn't work, that's the first criteria. The second one would be when you have the proper technology. You need all this equipment. You definitely need a microscope, and you need ultrasonic instruments, and you may need specialty removal equipment. So if you don't have this technology, there's no way for you to remove the instrument. When you have the operator experience, when I first started removing instruments, I started removing simple instruments, coronally fractured in the middle area, and then when I became a little more experienced, I started moving towards the apical. So you need a little bit of experience with regards to more consistently removing these instruments. When the instrument is ahead of the curve, لما يبقى مكسور في المنطقة اللي انت شايفها جوه الكنال، طبعا ده يشترط ان يبقى فيه microscope او at least loops to a certain extent. So in a case like this, on the left you can see I can see the instrument, so it would be easy to remove, and this is the case I showed before. When I look into the canal, I cannot see the instrument, I can only see dentin. So if you can't see the instrument and approach the instrument directly, it's going to be very hard, nearly impossible for you to remove it. When there is sufficient remaining dentin thickness, sometimes roots are thin, and like I said, when you are trying to remove an instrument from a canal, you need to create space around the instrument, and sometimes if the root is very thin, it can be a possibility for perforation. So it's very important that you have to consider the amount of dentin circumferentially around the instrument which has been separated, and you have to look very closely, especially in molars, to the danger zone, because it's very, very common for you during the process to perforate. There you go. You can see the difference in the diameter of the roots from coronal to middle to apical. Alright, so what influences the success of my ability, or my ability to either remove or not remove instruments? Number one, the position of separation. The more coronal the instrument, the easier it is to remove. The further you move apically, the more difficult it is to remove. Although there has been some research, which has shown that the success over time over apically fractured instruments is a little higher if the instruments haven't been removed, but still failure rate increases. The size and length of the instrument, whether it's large, long instruments, as we've seen, if you've seen some research by Toriocci, usually need to be removed with removal devices. Smaller, thinner instruments can be removed easily with ultrasonics, and then when compared to larger, longer instruments. The original cross-section of the canals, when you look at the canals themselves, if these cross-sections are oval, irregular, there is space around the instrument which allows for possibility of bypass, as well as it becomes easier to remove because the instruments may not be as bound. The more bound the instrument, the more difficult it is to remove. The less bound the instrument, the easier it is to remove. Also, the cross-section of the instruments. Comparing instrument design, if you have a thick cross-section, there isn't much space around it. Also, these thick cross-sections can bind more to dentin, so they're more attached to the dentin, making it much harder for them to be loosened. While if you look at the different flute designs, if you have a design of a flute which are tightly wound, the number of flutes in contact with the dentin will increase, and the amount of space around the file will decrease. If you look at the more recent rotary instruments, most of them have very wide flutes because of the wider pitch and helical angles, narrower helical angles, and because of that, it's a little easier to bypass, and sometimes they're not as bound to the apical, to the dentin as other instruments. The material of manufacture, in my opinion, stainless steel instruments are easier to remove than nickel titanium, because when you apply ultrasonic energy to stainless steel, they don't absorb them as much as nickel titanium. Nickel titanium absorbs ultrasonic instruments, and they begin to fracture into pieces. So for me, stainless steel instruments are a little easier, Also because most of the rotary systems made out of nickel titanium have a larger taper, so they're more engaged in dentin compared to ISO standardized stainless steel instruments. Also, another factor that affects the ability to remove is this instrument bound or unbound. هل الانسترومنت معشق جوه الدنتين قوي ولا it's slightly broken. If instruments fracture by cyclic fatigue, they're usually less bound and they're easier to bypass and remove. If the instruments are fractured due to torsional fatigue, that means that the doctor forces the instrument into the canal with resistance, and then it fractures in contact with dentin. These instruments are much more difficult to remove when compared to unbound instruments. So this is, for instance, a case which I had done. This patient was referred after the dentist tried to remove the instrument. Now, if you look very closely here, I'm going to magnify. You can see that the instrument looks like there is space around it. So it should be easy to come out. This is probably an H file. You can recognize the shape of the file from how big it is. It was a very large file, I think maybe a size 45. And the instrument was fractured, and it looked really loose. I tried to bypass, and I couldn't bypass at all. The previous doctor tried to create space using a tapered stone. You can see even the shape of the tapered stone here. It's very clear. And here, after removal, I could not bypass, so in this case I removed. But I just wanted to show you that the process of removal will result in serious damage to the root structure, sometimes irreversible damage to the point where the instrument, the tooth is no longer restorable. And if this happens, then it's بالبلدي عندنا بالمصري ضحيت بالأم والجنين عشان العملية تنجح. You're going to sacrifice the tooth to do the instrument removal. Maybe another option would have been better in a case like this. With regards to success and failure, this research also is about maybe it's old. It's from 1999 to 2014. But generally, there has been well-established documentation over the success and failure of removal compared to bypass. Bypass has a higher success rate of the cases you choose to bypass, nearly in the range of 48–54%. There is a research at 84%, but my clinical experience tells me I don't bypass 84% of my cases. While instrument removal, or the percentage of success of the cases you choose for instrument removal and retrieval, then you have a range of about 30%, so maybe about 3 out of every 10 cases you will be able to remove. The other ones you will not be so successful. So how is it done? There are many techniques, but generally they're broken down into 3 different techniques. You can have grasping instruments to pull out the instruments that are fractured in the coronal area, very similar to the Gates Glidden drill. When it fractures in the coronal area, you use tweezers or hemostat and just pull it out. You can use ultrasonic instruments, or you can use microtubes and loop systems, which are specifically designed systems for removal of separated instruments. So this is a video with an example of a coronal fracture. You can see that I'm trying to create space around the instrument. And it takes time, you need to create space, and obviously you can imagine if I was doing this same procedure in the middle or the apical third, there would be possibility that this the perforation occurs around within the root system. And there you can see the instrument coming out. Yeah, very clear. There you go. Okay, and then there are specific instrument systems. You have, like I said, loop systems which depend on a wire which strangulates the instrument segment and attaches to it when you pull it out, or it can be in the form of a tube which is like a metal syringe with a hollow area which attaches onto the top of the instrument and then is engaged with some sort of mechanism from inside the loops, from inside the tube system. An example of the tube system would be one like this, and then this is an example. The tube system basically has a tube with an attachment. The tube places onside the instrument, and then there is a button you press which pushes a metal extender that engages the instrument and it attaches to it, and then you just pull it out. While in the case of a loop system, it's like a loop which you engage on the instrument, so it holds it and you pull it out. This is an example of the loop engaging with an instrument. This is the Teriachi system. Okay, and sometimes things don't come out. These are cases which instruments have been pushed out into the apical area or have not been retrievable, whether it be in the apical or in the middle or the coronal. In this case, you need to think about surgery, whether it be replantation surgery, apical surgery, but doing it orthograde may not always be feasible or may not always be the solution. Again, I would like to thank Dr. Mustafa and Dr. Al-Qasim for their invitation. شكرا يا دكاترة، ربنا يبارك لكم كده ويرفع عنكم البلاء. If anybody needs anything from me with regards to this lecture, I will be available. You can post onto the comments and I will answer as best as I can. Because of the internet problems and during this time, I had to pre-record this lecture, and it's going to be uploaded, and then I will be able to answer your questions in the comments. Please communicate with me, like I said, on my Facebook, on my my mail. Please, at any time I will be there and I can answer any of your questions. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh.